This project started because CMS decided that they wanted to remove some diagnoses from their inpatient-only list. They removed the total knee replacement and the total hip replacement. By the time 2021 came around, we had gone from 100% of an inpatient population to 90% outpatient population. We needed to find a way to decrease our length of stay without increasing our readmissions, and the research shows the best way to do that is to get those total joint patients up and moving on the day of surgery. The orthopedic surgeons began talking to the patients in their clinics that they should only expect to stay one day. After that, physical rehab became really involved. We worked on determining the reasons patients weren't getting up on the day of surgery. Then nursing began mobilizing patients. If we'd expected nursing to start the rest of the patients that physical rehab hadn't been able to get to, that would have been about 40% of our patients. And our volume is close to 1,000 every year. That would have been a pretty big burden on the night shift of nursing.
That first therapy tried to get all the patients up and moving faster, and then we realized that that was not the best way to handle that, because therapy was walking some patients, nursing was walking some other patients, and sometimes they were both walking the same patients. So we quickly learned that we were going to have to work together.
We're trying to figure out a way to get them up quicker, and how do we best go about doing that? And the solution that we came up with was educating nursing staff to where nursing staff is going to be there 24/7. Therapy is a great resource, but their hours are different, so we wanted to bridge that gap to where there wasn't an interruption in getting those patients up, whether it was after hours on a weekday or over the weekend, whatever the case may be.
In order to help get this done too, we realized some of those late surgeries were coming up at times that we really felt like we should be able to see the patient, but we maybe didn't have enough hands in the building. Nursing already their hands were full. And so we hired a specific physical therapist to come in and work the late shift. So he typically works from 11 to 8, and he's able to see those surgeries that come up late.
The therapist that stays late and the patient care techs on nights, that has been the game winner, honestly. At night, our techs are just rock stars, and they really step up and help bridge that gap and work with that therapist that stays late. And if he's unable to stay even late enough to get everybody out of bed, we take up that responsibility after that.
By making all of these changes, having all of these different teams work together, and having a physical therapist work later, we went from 62% of our patients getting up on the day of surgery to 92%. We went from 6% of our patients ambulating 100 feet on the day of surgery to slightly over 70% of our patients. And that corresponded to a lower readmission rate. We went from 6.5% readmission rate to a 1.25. For our length of stay, we went from 2.1 days to 1.1 days. And what that meant for the health system, we avoided approximately $1.1 million in cost due to the decreased labor costs and the decreased medical costs associated with a lower length of stay.